If you haven't done so already, please put your name and your number in there so I can put you on the roster.
Hi out there in virtual land. Yeah, there's one run sheet I didn't print up, but I remember it very, very well. To review, it's not a head injury per se, but it's a head thing. We had a run, what was that, 2 weeks ago? Yeah, somewhere in there. A 72-year-old gentleman who's very active, still working. He's actually digging in a trench or digging a trench out when he has sudden onset of left-sided weakness. Do you have a headache? Yeah. Yeah. Headache and just sudden weakness on his left side. This was witnessed by his coworkers. He was seen by first responders to be quite weak on the left side. Woods picked him up. Alexis was on that run. When he arrived at the emergency department, she opted to bring him to us rather than to UMass because it was as soon as he was pretty dense on that left side. Time is of the essence in the stroke. If we can intervene within 3.5 to 4 hours with a thrombolytic, all the better. This guy may have a good outcome. Well, as it turns out, once the guy hit our door, his vital signs looked pretty good, as I remember, right? Rock solid, talking to us. You remember the whole event, knew where he was. His speech was pretty good. Within the next hour, this guy starts to look really funky, starts to go downhill. But we know now why, because we've already done the CT. He got over there pretty quick, I think, within 5-7 minutes of arrival. This guy had an intracerebral hemorrhage on the right side, explaining his left side deficit, and it was pretty big enough to cause a midline shift. So it was shifting towards his left side. And we could see that clinically as the guy was starting to deteriorate. He was becoming more and more bradycardic, more and more hypotensive, and more confused. His GCS was declining. So we opted to intubate this man to protect his airway and made the decision that we would fly him to UMass. So that's all well and good. The trouble is, once we started attempting intubation after we administered the usual muscle relaxant pain medication and paralytic, his airway looked like garbage. He had a little bit more of an anterior look. His airway was a little narrowed. He had some secretions in there, which in retrospect was probably a little, I think maybe he aspirated a little bit as he was declining indentation. Because if you're not fully awake, you can aspirate, correct? Just ask your spouses or significant others if you snore at night. But anyway, it soon became apparent after 3 attempts, and there were 2 PAs and myself in the room of all of us attempting an airway, even with an assistant of a bougie and the video scope, Mack or Miller, we were going nowhere. Meanwhile, this guy's saturations were going from 96, pre-intubation, 92, to 88, to 76, to 55. My heart rate's going from 110 to 120 to 140. It's like we're losing this guy pretty fast. And on the monitor, he went from sinus rhythm to sinus bradycardia to wide complex sinus bradycardia. And you know where wide complexes like to go. Down 6 feet under. And his pressures were starting to get quite soft. We had opening, I think his initial pressure was like 120, 140. He was pretty normal. Yeah, he was starting to be, 101, 98, 74.
Apartment number 18. Going to be to assist the party was getting back inside their apartment. Again, 43. Regular London apartment 18. Berlin says back into the apartment.
Another life rescue. I'll say no more. So anyway, obviously this guy is going from bad to worse to very worse. This is a classic head bleed. So this is not a concussion, right? By definition. This is a spontaneous bleed, likely from a ruptured aneurysm causing a stroke. This is a hemorrhagic stroke. This guy's in deep trouble. Now I can't get an airway. We failed 3 times what's my option? A surgical airway. So Gary was with me, Gary Vinoga, one of our PAs. You all know Gary is well seasoned. I was busy going back and forth with family. That was his wife, I think. So back and forth with her. I came back in the room. I'd given Gary permission to do a surgical airway. Did the prep. We did a trach. We got a 6 French in this guy. All of a sudden, his heart rate gets better. His blood pressure normalizes with pressors. And we've got this guy well saturated, 98 to 100 on a ventilator. We've got pressures going, fluids going, and we've got this guy stable for air transport. By the time Lifelight got up there, they had a critically ill patient, but they were able to get him to UMass. I found out later that he was able to be intubated, and then they closed this wound and just managed him medically. They made him comfort measures only, enough for the family to gather around him. He had actually survived almost 6 days down there before he succumbed to his hemorrhagic stroke. But it gave family members and extended family, because he had a few extended family members out of the area, gave them time to grieve, to see him at least alive, and to wrap their heads around it. So, good choice on your part, because had you transported this man, you would have had a dead patient in the back of the rig by the time you got to Whistler. So between here and 55 Lake Avenue, that guy would not have made it. So yeah, a guy that deteriorated that quickly. This is all within the first hour. So there's a lot to be said about that golden hour. This guy crumped, and I haven't done a surgical airway, and I can't tell you how long. In fact, I think the only one I did before that was last year in my residency, first year of practice. I can't remember. So it's been a while. The same with Gary. I don't think Gary had done the surgical airway in I can't remember how long. So anyway, that's a good case to review. Everything was done correctly and right. The initial assessment, primary survey, secondary survey was all well done. It was identified very early that the patient was stroke. It was radioed in as a stroke protocol. It was, in fact, you put the tones off for us to stroke alert. Everybody was ready. We had the patient over to CT in a very timely fashion, so everything fell into place. That case, by the way, is undergoing root cause analysis evaluation, because any patient, with the above and beyond in the department, we review. And we found in review that everything was okay. The only thing minor was we didn't have a suction apparatus set up in the room. The reason is because earlier that day we had used the room for a cardiac arrest, and the suction apparatus had been taken away because it had been used, it wasn't replaced. So minor detail, but became a major problem when we had airway trouble. We're intubating this guy and all these secretions and reach for the suction that isn't there. Case in point. Always run your equipment. And I'm sure you guys are very, very faithful in cleaning out the rig and making sure you restock, before your next call, hopefully. 2 calls back to back, you're not a happy review make, but do the best you can. This is not so much a head bleed as it is a head bleed and a head trauma. I thought this would be very apropos for assessing head trauma. This is a male, 65 years old. Let's see. I'll dig to the body of the report here. This is a gentleman that was assessed. He was unresponsive after a fall. On the scene, the wife says that he was upstairs, and she's sitting downstairs when she heard a loud crash, and finds that her husband fell down the stairs. So he's at the bottom of the staircase when first responders get there. Fortunately, she called 911 right away. Oh, by the way, my husband had a few before the Pats game, so you know already that this is complicated with alcohol on board. I don't know if anybody in the area that drinks alcohol. It's such a strange thing to me. But afterwards, no drugs. He doesn't drink on a daily basis so much as before the Pats game. And sometimes the way they play may deserve a drink or two. I don't know. But he wasn't complaining. He was wide awake, so that's good. when in your assessment, you're telling me what he says or how he interacts with you, that's very good for the reader to tell me what his GCS is. If he's able to answer questions, then he's got a GCS of 15, more than likely, right? So I have no chest pain. I'm not short of breath, no other complaints. He thinks he's on blood thinners. Doesn't it amaze you that patients are on medication and they don't have an idea? I'm on a white pill, a purple pill. I think my doctor has me on a blood thinner. I don't know. Or are you on Coumadin? I don't know. Do you get your blood checked once or twice a week? Yeah. Yeah, sorry. Frustrating. So anyway, he's found supine at the bottom of the second story staircase. Interesting, the writer says the patient was naked. And snoring, erratic respirations. That's interesting. He's able to tell you, he had a few before the game, and he's not complaining of anything else. He's not wearing clothes. So, interesting. Moderate amount of blood is noted around the head of the male and on the face. That changes the picture, doesn't it? The paramedic student that's along the line here, initiates a C-spine immobilization. That's awesome. Cardiac monitor is placed, rapid trauma assessment is done, and here it is. Patient is now unresponsive. Whoops. A GCS of 3. Airway suction, attempt to pass for obstruction, moderate amount of blood in the airway, no obvious missing teeth or visual obstruction. The patient is placed in the left recumbent for airway. Not sure. Must have been because of the secretions in the log roll. Okay. Additional suction applied. The patient's bled from an occipital laceration. Notice when the patient was log rolled. No obvious open skull fracture or crepitus. By the way, where else in the skull are you going to look for a posterior fracture of an occiput? Anybody know? Yeah, good job, you guys. That's called a battle sign, right here. Or no, that's not a battle sign. It's underneath the orbit. That's black and blue raccoon eyes. But if you see black and blue or crepitus in behind the mastoid bone, remember the mastoid is connected to the occipital. So if there's an occipital fracture, sometimes you'll see bleeding there with black and blue. Okay, this guy has an occipital laceration. He's obtunded, GCS of 15, not protecting his airway. And he sounds like he deteriorated pretty quick. Sugar is 189. That's good. I'm glad they reported that. About 200 cc's of blood is on the floor where the patient was resting. I like that term, resting. I decided to take a nap. Request for med flight immediately. That's a wise idea. So what's your overall impression? I've been drinking and watched the CAT scan and I'm naked. Is the guy in his right mind to begin with? Probably intoxicated. Maybe he took a shower. I don't know. But no one else was upstairs. He wasn't having an affair with the neighbor. But leave that out. So obviously this guy is already out of his mind. He took a stumble. We have to assume he's intoxicated because he and his wife admitted to a few beers before the game. And you and I know that 2 beers is always multiplied by 2. So down the stairs he went. He has a trauma, right? Head trauma for sure. Do you suspect any other trauma on this guy? Absolutely, without question. Okay. Would you immobilize the neck? Yes. Airway protection for sure. Yes. Intubation at the scene. Yes. Very good. Any other things? You probably should record a secondary survey here. Let's see. 12 lead, no changes. Scoop stretcher, patient secured. Pupils are very good. Here's a pupil thing. Noted to be 3 millimeters non-reactive. Our non-reactive pupils are worried to you, especially yes, in case of head injury. He was noted to have bilateral rest sounds. That's good. No crepitus on the chest. That's good. No gag reflex when they intubated the patient. Are you nervous? Yeah. There's no gag would indicate a deeper head injury. And if he has a posterior occipital injury, what's close to there is the breathing center. of the cord, right where the cord leaves the foramen magnum. There could be a real bad problem there. He's got a laceration on the scalp. We already noted that. Nothing in the limbs. No other assessment. Yeah, just. The writer notes no colon or great Turner sign. That's very good. Colon is the black and blue around the umbilicus. Great Turners is the black and blue along the side. Not incontinent urine. Great. Pelvis stable. Great. No malrotation. Small hematoma left lower medial leg. No obvious fractures. Very good assessment. In trauma, you guys, you want to do the secondary assessment, which is very, very helpful to the reader. Remember, this patient is being transferred immediately from the scene to tertiary care. Tertiary care, they're a little persnickety and they like to see that you've done as much as you can on the scene to secure the patient, make sure they're stable. You did it as quickly as possible. So this is good. The life flight came to the patient. I'm going to give you some interesting vital things. Initial blood pressure is 140, 88 on room air. That's interesting. Labored breathing. Patient was able to speak initially and then the blood pressure next 135 over 92. Highest I'm seeing is 152 or 84. But good, the patient didn't become hypotensive. Are you worried about hypotension in a head injury? Yep. How would you treat it? Fluids. That's correct. Oh, you get an egg. I'll give you an extra credit. Okay. GCS is noted. You guys did a really good job at seeing the deterioration. Oh, this is interesting. I didn't see this on the initial review of the chart. The patient went in and out of AFib. All right. Have fun. Save a life. Yeah, so the patient was in and out of AFib. There's some critical field that documents that. And that's just an interesting fact to know. That's not something you would have to necessarily treat in this scenario. If perchance, let's complicate it a little bit. If perchance you're treating the head injured patient, you've established the airway, now he goes into AFib RDR. Let's say he's tacking away at 180, 210. Would you treat that? What do you think? You just leave it be? Just give him the fluids? Yeah, 180, 210. Yeah. I wouldn't fault you for maybe a little sport of guilt. The trick is this guy's hypotensive from shock, and he was, well, he could be. He wasn't in the actual scenario. So in this actual scenario, you've got room to play with blood pressure. But if he started dropping his blood pressure, then it'd be a little tricky.
Well, I guess that's the question. If you have the heart rate of 210, is he hypotensive because he's in shock, or is he hypotensive because his heart rate's too fast and he doesn't have any cardiac output?
Exactly. Yeah.
That's
now
the
the nurses have been. I've tricked them on this many times. When they're AFib RDR and they drop their blood pressure, the nurses look at me like I got two heads when I ordered the DILT, because you're giving a hypertensive DILT. Yeah, because Tom made a good point. Cardiac output is squat with a heart rate that fast. You improve the heart rate, you improve cardiac output. What does that do to the blood pressure? It raises the blood pressure, right? So the nurses are just simply amazed that when you give them the DILT and their heart rate goes from 210 to maybe 106, and their blood pressure goes up to 110, that's pretty impressive. So it does happen. Yeah.
You're a wizard, Harry.
Yeah. And the nurses applaud me. I'm not a hero, it's physiology. Okay. I can't remember if I reviewed this case with you before or not, but I'll do it again. Just hope I'm not too redundant. Because this is a good head trauma case too. Then fortunately did have a good outcome, but a very long hospital stay down at UMass. 52-year-old female. You're called to the scene. It's a car accident, unfortunately. She's unresponsive. I'll read you the narrative. There were some pictures along with this one too. It's pretty impressive. You're intercepting with first responders for an MVC. This is a female patient, unresponsive. She's in the driver's seat of her car. She is restrained and airbags have been deployed, but here's the but. The driver's door wasn't there. Did I review this with you? I don't remember. But,
I don't know,
yeah.
that's more-
If you know this case? What did you? Yeah. Oh, okay. Yeah. Yeah, it was GFD Rescue 3. Were you on? Okay. Yeah, you guys did a good job, by the way. But man, it was a mess of an accident. So right then and there, let's stop. You see that the door is nowhere to be seen, but the patient's still in the car. What does that tell you about the mechanism of injury? Good or bad? Pretty easy. You know, most of the time the door should be on the vehicle, but it was not. So the car was struck on the driver's door, 8-pillar by a large van at high rate of speed. Speed limit on this road is 50 miles an hour, so it gives you an idea. It's good that the writer includes that in the narrative because it gives the reader a perspective of just how hard hit this patient was. Significant intrusion into the doorway. The vehicle also had significant damage and was rolled over once. She is unresponsive during the duration of treatment. Pupils are equal round and sluggish. There's no JVD or tracheal deviation. Airway is clear initially, but then noted to have blood in it prior to intubation. It's interesting that intubation is considered right away. Good for you. You know, this patient's unresponsive. So what's the GCS in your head? Yeah, she's below 8, right? I was always trained that anything below 8, that gets an airway, right? So it's obvious. And most of us would know, even if you were in training and you didn't have your full certification yet, any of us would know this patient needs airway help. You know, she's in an open car and she's, you know, like this. So that tells you something. So there's blood in the airway. Bougie was utilized and placed with ease. Awesome. You may need assistance there. Laceration of the patient's left cheek. Makes sense. Because if that door is knocked off, maybe some glass or something hit her cheek, right? Blood noted to be draining from both ears. Negative halo test. Interesting. So is it bleeding from the brain or not from the brain? Probably not, yeah. Halo, if it were positive, would be cerebral spinal, right? So halo, for those of you who don't know, it's where you put the blood or the fluid on paper and you see this ring. So you see where it was dropped and then you see this halo around it. That's cerebral spinal.
What's the
That's
percentage of that being?
What's that?
What's the percentage of that being predicted though? Like
Really small.
I was just going to say it doesn't show up very often.
The positive predictive value, I think, is less than 10%, 15, something really silly low. Yeah.
So not as much as we used to.
Yeah, it's really not it's something fun to do, but it's not very helpful. Just something to observe because it would alert the attending and the receiving physician to look deeper. They're going to get CAT scan. All right. Blood in the ears, that means that there's a fracture there. That's fracture to proven otherwise, because if there's bleeding, that means that the encasement around the ear has been disturbed and blood is going from the middle ear to the outer airway. Edema and ecchymosis is noted around the left orbit and forehead. Fracture, no fracture. Probably an orbital fracture there, right? Here's the thorax. The thorax is stable, it's symmetric chest rise, so that kind of rules out a flail check, not completely. Chest wall is grossly intact, which is pretty amazing for this patient. Noted evidence increased work of breathing and accessory muscle usage. And the trachea is midline, so that kind of leads you away from the pneumothorax. Could she develop a pneumothorax? Absolutely. Abdomen is kind of quiet. Pelvis is stable. She's continent of urine and feces. That's good to know. Maybe not a spinal injury. Extremities, equal bilateral circulatory function in both upper and lower extremities. Patient not answering or following any commands. So that, along with unresponsive, kind of adds to that whole GCS score. At one point, she appeared to have simultaneous cerebral posturing on the left, the corticate on the right. That's a phenomenon you don't see often, but it can happen. Depends on where the bleeding is in the head. It was noticed the patient's left leg was rotated inward, but no shortening was observed. Remember, she was hit on the left side. So the assessment's really easy. It's head trauma. Wouldn't take a rocket scientist to figure that out. Primary secondary assessment, cervical collar applied, appropriately so, extricated to long backboard. Life flight has been requested to meet AMS and assign a landing zone. Patient transferred, stretcher secured, seatbelt, blah, blah, blah. So ECG is performed. SpO2 is done. I'll give you those numbers in a minute. Respirations became more shallow and erratic. And now that she's in a better spot, she's intubated with a 7.5 ET tube. 22 to the left. Bougie utilized passing through the blood that was noted in the airway. Good quality airway management on this one. If you have something in the airway that's visible that makes it difficult, that's why we went to the Bougie and the guy that had the hemorrhagic stroke, because of the secretions that we were seeing, making it difficult to use the video scope. So we took the next step. Good job. Placement's confirmed, and everybody knows how to confirm an airway, right? An ET tube is confirmed by vapor, by capnography, by listening to the lungs. And am I missing something?
Mosquito tube, the long sounds, the end title. Those are the biggies.
Yeah.
Oh, chest rise.
Chest rise. Yeah, that's.
And listen to the abdomen.
Yeah, you listen to the abdomen and make sure you're not inflating the stomach. Yeah, Danny Boy did that with my very first intubation. Oh, I got it in. No,
Well, if you
didn't.
hear it air in all three places, you know you got a really bad day.
Yeah, I gave the guy a lot of reason for it. There was some gag reflex with the ET tube. That's helpful to know. Transported to the landing zone. Helicopter. Let's see. 1 milligram of Versed is administered. Patient was gagging a little bit. Verbal. Ooh, now this is it. I had forgotten this. I haven't reviewed this case. The van had 11 patients in the second vehicle. Wow. Yeah.
That sounds familiar.
So now from there, yeah. So the van was like a school van or, yeah. I don't think any of those were really hurt really bad, right? Full-size passenger. That's interesting. Wow. What a case. Holy cow. So, anywho, let me go back.
Mark O'Brien, who was on the call, he's on the chat, says that apparently it was a van full of a construction crew.
Oh, okay. Yeah, that's very helpful. I hope for those of you that have reviewed this before, my apologies, but I thought it was such a kind of an interesting case. Plus, I wanted to give you an outcome. Because a lot of times you don't hear the outcomes. It's always good to know that you did make a difference. Saved a life. So, initial blood pressure 120 over palp, 99 on room air. Pretty amazing. Respirations were labored, however, at 28, and they became shallow at 30, and that was looks like 13 minutes after initial assessment. Let's see, go down here. 133 over 87, 135. Doesn't look like she got hypertensive. And this is after intubation. Electric ventilator not available. No, I'm just kidding. Yeah, it looks like she really didn't lose a patient. Well, yeah, I don't have. Obviously, there's not a lot of vitals here because the helicopter got there pretty quick. And the medics and EMTs did what they had to do to stabilize the patient. So, before I show you some pictures, let me tell you how she did. She gets down to UMass, arrives at the trauma bay. She's intubated, ventilated. They do their thing. They diagnosed her with traumatic hemorrhagic shock because she did start to go into shock shortly after arrival at UMass. So good timing on your part. That's the last thing you need to medical shock in the field. They gave her 5 units of Taxels, 2 units of fresh frozen plasma, and 1 unit of, what was there, cryoprecipitated. She's OPAS, which made it easy. Yeah. So they treated her for shock. They did massive transfusion protocol. They found that she had a subarachnoid hemorrhage with loss of consciousness, obviously. She also had a subdural. So this lady had 2 areas of bleeding, probably poop counter, poop maybe, right? Without me looking at the scans, I couldn't tell you. She also was found to have a pneumothorax on the left side. Now, can you have a pneumo and not detect it on clinical exam? And the answer is yes. Don't beat yourself up if you miss small pneumos in the field, because that can happen. So that was treated with the chest tube. She also had a closed left zygomaticomaxillary complex fracture. So she fractured the orbit, the zygomatic bone, and the maxillary bone. For those of you watching, that's this complex right here. So she took a good hit on her left cheek. She had intra-abdominal hemorrhage. Get this. She ruptured her spleen. She had a grade 4 splenic lac. Grade 4 means the surgeons will get some income. She had a liver laceration, which was repaired. Diaphragmatic injury, and you can guess what size, right? The lady was hit from the left side. So the force of the trauma, it literally ripped her diaphragm. She had a sternal fracture. So the liver lac was repaired, the diaphragmatic injury was repaired, the spleen was removed. She had a splenectomy. She also was diagnosed with diffuse axonal brain injury. That diagnosis came after 24 hours in the ICU because she was not waking up. And they determined that she qualified as a DII, loss of consciousness for more than 24 hours. Remember the definition. She also had closed non-displaced fracture, the second metacarpal of the right hand. So that's this bone right here. That was set by orthopedics, no big deal. Closed pelvic fracture. And we found out later that she uses alcohol on a daily basis. So she underwent the usual protocol to prevent seizures. She was given seizure prophylaxis, both for the head injury as well as alcoholic history. She was given thiamine and folate, 2 vitamins that alcoholics often get depleted in. And long story short, this was on the 11th of January of this year. She was discharged the 24th of February. So that's an extended hospital stay. And you can imagine the dollar signs behind that one, including the surgeries. And she had surgery to her face. Maxillofacial repaired this. Orthopedics repaired this. Trauma surgery repaired the intra-abdominal thing, and the chest tube, and plus all the care behind it. She went to a rehab facility in New York, Burke Rehab. I think that's because they specialize in TBI patients, more than likely. I don't know all the particulars of that institution, and of course I can't go any further than that to see how she's doing it. Wow. 52-year-old lady hit by a van full of people at a very fast speed. It's a wonder she didn't die. I'm hoping and praying that she has some semblance of a life, because now that she's TBI, it's going to be a long road for her. She more than likely has some of those complications we talked about. So I thought it'd be a good case to review, because a lot of what you've seen in this particular case review, she has or had, at that scene. And I did promise you.
Someone was asking if she was discharged with any specific deficits.
Yes. Sorry. She had some speech difficulty and word recognition. She also had, what did they call it? I forget what the fancy term is, but where you get your sentences mixed up. So in the English language, it's noun, verb, and adjective type of structure, and she was putting verb before noun sometimes. Some languages do that, but not the English language. There's a word for that. So she was missing words sometimes, but and tripping over, word structure and sentences. The other thing they mentioned too, and I forget the term for this too, but She was labile, emotionally labile, but there's a fancy word for that too. So I don't know if you can see, let me bring it.
Yeah, let's bring it right up there.
Yeah, you can see the intrusion in the vehicle. This is where she was sitting. The whole door is missing. You know that the pillars are gone. Yeah, pretty nasty. Not walking around. Not fun, huh? The insurance company did not total this guy down. It would be just like an insurance company.
So while you're showing that, we had a question about the idea of having, say, somebody who's decorticate on one side and cerebral on the other.
That's it, that bleeds. So my hunch is that one bleed on one side was causing posturing in a different fashion than on the other. Just depends on where it's located.
So the two different bleeds were causing the two different presentations.
Yeah, that's right.
Oops.
She may have been hitting like the front of his ankle, towards his ankle, a little bit, to take that airbag off. Either that or the impact was so fast. Looks like there might have been a side back there. It's cheap and tell you how old I am. I play on the back of your seatbelt. Yeah, we went on Florida. We were in one of those Florida LTV nice ridings. So this nice riding was on the way back. Yeah. It's right. I've seen people die. There's something to be said, everybody, that the seatbelts and airbags do save lives. Granted, she's in bad shape and probably she'll be altered a little bit the rest of her life, but she might be living a little bit of a quality of life, which is good for her and family. I don't know if she had children or husband or whatever, but it's a life saved. So kudos to everybody for doing their job. It's just amazing to me that someone could survive that. I was telling Colleen that I've seen people die with far less damage than that. It's pretty incredible. So, all right. We're pretty much timed out.
We're getting close, yeah. Maybe one more, that'll be it.
Yeah, y'all can be patient for one more, and we'll do this one, okay? This is another fall patient. This is a 68-year-old. Now this is at the prison. So, this is a fall in a prison cell block. Now I have to say, sometimes we think it's incarceritis. You know, they want to get out of jail free card, so they call 911. You know how that goes. But as we read down through the narrative, you will see why 911 was called. Possible head and neck injury. On the way, the CMED gets on your radio again and asks you about the availability of life flight. Oh, well, that changes the picture. Maybe it's not incarceritis. They are flying, they accept the mission. The patient is found lying supine on the floor. Or if we're watching the television show Criminal Minds, we'll call them the unsettled. They always use that term, unsettled. One of my favorite words for a crime scene. Anyway, he's lying supine on the floor in a pool of blood. Police report, the prison folks, that he was under arrest for OUI for liquor and was being monitored in the cell via closed circuit television. They noticed the patient attempting to flood the cell by washing the sink with his blanket. That's interesting. Blanket was taken, water shut off, and then the patient heard a loud bang, went to go to check and found him laying on the ground in a full blood, unresponsive but breathing. Sounds like he slipped in the water, didn't he? Yeah. Whoops. I wonder if there'll be a root cause analysis on that one. Patient was immediately placed in cervical collar, and so his C-spine was secured. Good job. Now, the problem is when somebody's in confinement like that, no matter what you do, and this is our problem over at the hospital too. If they're in confinement in your room, all bets are off. Even if you have eyes on them 100% of the time, they can still fall. We had a case the other day. This guy came in because he fell at home. He was sore on his left hip, left pelvis. He'd been there for 2 hours, and he was just waiting in line for a CT and his x-rays. He had to pee. So he calls the tech in. The tech hands him the urinal. I can use it. I can use it. The guy's lucid, complaining nothing. Both bed rails are up. The curtain's pulled so he can urinate. The next thing you know, Dan, we need you in 14. Run to the room. The guy's on the floor, face down, blood around his head. He had fallen out of the end of the bed and cut his eyebrow there. And from there, he started getting really weird, just confused. Not a head bleed, but we don't know why. He all of a sudden had some confusion. We intubated him because he was really getting altered and sent to UMass. And that's all I know. So things can happen, and that's probably what happened here too. No matter what, it can happen. The floor would be wiped down more than likely, but it was damp, slipped on the cement, and down he goes. So he's log rolled, placed on a scoop stretcher, neck is immobilized, everything's secured. Due to the blood loss, line has started. He's given a fluid bolus of 250 milliliters, 3-lead cardiac monitor, sinus rhythm, so he's not too fast, not too slow, no ectopy. Another line is started. Point of care glucose is 118. They're estimating his weight around 55 kilos. Now this is good call. The patient was given TXA by the paramedic. And for those of you who may not be really familiar with, TXA is tranexamic acid. It is a substance that immediately causes clotting because it blocks thrombolysis and blood breakdown in the body. It was developed, I think, by the military, correct?
That's who we got all the data from.
Yeah. They researched it and then kindly gave it to us for field use. If the patient's in suspected hemorrhagic shock, which this guy is, it's a good call. It's a good drug to give because it works immediately. Airway is secured. He was intoxicated, as we alluded to earlier. That's why the police had him under arrest. Now, the medic, when she opens up the airway, sees copious amounts of blood. Airway is suction, and the videoscope visualized, the macro blade used. On the videoscope, vocal cords are open. Patient took a breath and intubation completed. After suction, she did use a bougie. Okay, that's wise move too. The bleeding might progress and you might lose visualization. No missing T, positive misting. All the steps are taken to secure and make sure the airway's in the right place. Capnography, misting, end tidal. This is all good. BDM was used. Patient did gag a little bit, so they give him some voice that looks like, yep. Fentanyl for pain. Plainly zone across the street. Let's see. Mentions pupils here. Pupil size is a little off. Can patients normally have one pupil that's bigger than the other?
Yes.
And the answer is yes. That's a normal variant in a lot of people, so don't let it throw you off. It's good to note, especially if it's a trauma patient, but it doesn't necessarily mean that there's a problem there. Okay. Now, the patient did try to move, but it was only moving his left side and not his lower extremities. Give or take, that's an observation. Does it mean anything? I don't know. Time will tell. That's a good case. And the patient life flight. Here's the vitals. Initial blood pressure is 170/89. Got as high as 200/96. As low as 162/78. Respirations between 13 and 12. 96%. Never really dipped down. Blood glucose is 118. End tidal after intubation was 44. Do you think we should come down on that a little bit? 44 is a little on the high side, maybe.
The range is 35 to 45, so it's high end of normal.
Yeah. So current literature says to come down on that just a little bit. So you may want to breathe off some of the CO2. Not a big deal here because this guy's going to be flown out very shortly anyway. Oh, it's just one deal. Okay. I couldn't find anything on this guy, where he went. Right? I just couldn't access his chart data for some reason. Every time I typed it in, it looks like he went to UMass, but his name wouldn't come up. This patient not seen here, or may have the wrong name. I don't know what data points I was typing in, but so there you have it. Another head injury that was appropriately or inappropriately treated. What do you think? It's a good review. So in reviewing both of these or all these cases, you guys, we reviewed 3. I don't see any red flags or flaring things. All I can tell you is your assessments are timely. You assessed and made sure that you thought the worst and worked backwards. You thought, oh, the guy that fell down the steps is head injured. He needs an airway. The guy or the lady in the car obviously is head injury. She needs to fly out. Same way with the guy in the jail cell who slipped and whacked his head, is now bleeding and unresponsive. You know, same thing, assume head injury. So there you have it, a good review on head injuries and case review on trauma. Are there any questions concerning things, topics that you want to bring up? That includes you in video land. So. If not, if something comes to mind, you all know how to get a hold of me. Email, it's daniel.wilson@haywood.org. Email me anytime or call or just come up. You know me. If I'm there, my door's open, or if I'm working, I'll stop and talk to you. Just interrupt me. That's okay. I do sometimes look like a head chicken with a head of a. But I'll help you in any way I can. That's why I'm here. If you all down the road have any topic or concern that you want me to go over, or a case you wanted to bring up next time, by all means let me know. November 25 is our next M&M here at 6 p.m. It's a Monday night. It's the week of Thanksgiving, so I will not cook you a turkey you don't want me to cook. I help my wife with the stuffing. That's it. Okay.
We're only good full of turkeys, I'm sure.
Yeah. Yeah, that's for sure. Thank you guys from the bottom of my heart. I appreciate your attendance. Thank you.
Okie doke. For those of you online, I'm going to be sending copies of the roster to a couple of the EMS chiefs that I know need them. One person in particular did. If you don't see the roster by the end of the week, you can send me an email at pdartis@woodsam.com or contact your EMS officer to get a hold of me, and I'll get them a copy. Okay? Thank you.
Actually, Tom, I have the first hour.
Good to see you guys.
Just stop recording. Hang on.